Merhaba. Um, Thank you very much for the invitation. It is also an honor for me to be here. Um, I took the liberty of changing the slide and the title just yesterday to be a little bit more in keeping with really the broad scope of the Congress today. And so, although I'll be clearly talking to you about oxytocin, as you can imagine, there's been virtually no study that I'm aware of that has been published where essentially oxytocin has been given in depression. Probably our study is going to be one of the first, and we really focused on an imaging study to try and understand the brain mechanism by which it's going to possibly play a role. I will definitely share that with you, but put it in a context of really new development, and hopefully what I can communicate to you is one key point. We need to bring in more complexity to our research rather than an oversimplification that has taken place in the last 15, 20 years. I will start off with a disclosure. It's really hard to do these kind of novel research without a lot of collaboration with industry, yet most of my major funding is from the National Institute of Mental Health. The specific study that I'll be talking to you about with oxytocin has been funded by the Foundation of Hope for Depression Research, and the epidural cortical stimulation study has been funded by NARSAD. So one of the really daunting tasks about studying depression is really figuring out what are we studying in effect. And so what I would like to do first in my presentation is to give you a sense of what my perception is of the scope of the challenge that I'm sure translate back to you as clinician, as well as researcher in trying to deal with your patient. And then I'm gonna go over two early hypothesis testing to give you a forward look as opposed to Professor Mercer's kind of a summary of the last 50 years with clozapine. My hope is to give you a sense of where do we stand right now in terms of research and what should be coming up in the next 5-10 years, and hopefully something that you can either begin integrating, thinking about it clinically, or ultimately, if you're up for any research, I'm more than happy to extend collaborations. So the scope of the challenge really is that at the end of the day, depression is primarily a subjective experience, and that's what makes it very difficult to study. There are no biomarkers that we know of. We still are trying to figure out the underpinning of the brain functions and the brain circuits that are involved in depression. And there's a lot of environmental and genetic interaction that takes place. Yet, at the end of the day, the core experience is a subjective experience, and that's almost to some extent isolate our patient from ourselves, and we have to make some inferences as to where they are. I'm a big fan of Pamuk. I'm happy to report that I've read most of his work. But it struck me, I was on a plane and I was actually rereading Istanbul just to kind of refreshen up. And I read Huzun. And it kind of put it in perspective again, because it's really we're dealing about a component in our patient and probably in us is trying to understand depression either in a context of either you have it or you don't, or is it really an issue of a continuum that we all experience at some level, and it's a shared experience, and perhaps the extreme cases is what we clinically determine as needing treatment. So is depression really a disease? Is it kind of a binary mode where either you have it or you don't? Or as I was mentioning earlier, it's an extreme normal form of sadness. And is depression really fundamentally related to loss? Is it real or imagined? And this is maybe some of my byproduct of my earlier psychodynamic training and my psychiatric experience in Paris. But I fundamentally believe that the metapsychology and the brain are one aspect, and there's a lot of things for us to learn more about. And I'll come back to this issue of loss and separation because it's at the core of our hypothesis for why oxytocin might play a role in depression per se. And of course, the issues of attachment, again, the link between oxytocin, attachment, and really poor attachment as a predictor for developing depression down the road. And ultimately, what are the neuronal networks that are involved in depression? I'm a pharmaco researcher by training, but I have a depth and an interest in trying to understand the layers of that interface between brain, pharmacotherapy, and social cognition or metapsychology. And one of the issues that is really interesting is this idea of mental attribution, being able to read other people, relate to other people. It's probably one of the most unique social aspects of us human that differentiate us from animals. And we know that really plays a role actually in depression and in treatment of depression. So ultimately, the two things that I want to share with you is can oxytocin or brain stimulation modulate specifically what we call a prefrontal limbic activity in the brain. That is the prefrontal governance of a more basic emotional region in the brain, and ultimately changes the self-other experience, and could that in turn change the mood of the person. Depression is really complicated, and I think it's really simplistic to just talk about depression in general and not to pay attention to different phases of the illness. Obviously, the treatment-resistant depression was number of years and a ravage of toxic element that made the brain very different from first depressive episode. There's a lot of different ways coming at this problem, and I will be addressing those in much more detail tomorrow in my CME. Maybe this is an invitation for you to show up if you're up to waking up early. But it's really at the basis of what I've been studying for the last 15 years, how we can try to target our treatment at a specific stage of the illness, and not all depression is equal, and not all stages of depression are the same. This comes out to be fairly relevant because in terms of depression progression, really at some point earlier in the history of depressive illness in a particular patient, you will often find that there are specific social stressors that played a role. There are losses that could have taken place that precipitated the depressive episode. Yet with time, it seems that having a social stressor, an environmental stressor, is not that necessary, and relapses take place and almost on autopilot mode. Your patient tell you, I could understand why I was depressed 20 years ago. I don't now. My kids are out to college. I'm working. I'm happy. I should be happy, but I'm depressed. So there are fundamental changes in the brain that takes place with repeated exposure to this. And I guess really one of the most limiting factor at this point is how we conceptualize depression. I know people are working on a DSM-5, and probably this is one of my most controversial notes in this lecture, is I think at some level we need to go beyond the construct of DSM-4, in which we have to do a grouping of symptoms and then we come up with a diagnosis far from the pathophysiology that may have contributed to the illness. If you think about DSM, you have to have 5 out of 8 criteria to meet criteria for a major depressive episode. You can think of all the different combinations of 5 out of 8, and you would still be labeled major depression, and it's very unlikely that all these different combinations are one disease. And so instead, the research has really been focusing to try and hone down on some of the pathophysiology in the brain, and I've illustrated here work either in animals on stress separation distress models, or really the sadness system that overlay with the opioid system, and obviously those classic studies by Damasio in which people were imaged under sad experiences and kind of looked at the brain activation. And I want to highlight to you really that important overlay that evolutionary-wise we share with other mammals, in which that medial system, starting from the periapical gray all the way to the anterior cingulate, kind of plays a major role in our experience of sadness, our interplay with stress, and obviously what it comes out now to be one of the most classic findings in depression, this notion that the limbic regions in the brain are often hyperactive where the prefrontal lobe is hypoactive. This is a very, very simplistic but fairly representative a view of what might be going on. And so a lot of the hypothesis has been as to how we can restore this particular order. And there have been a lot of models. These are very complicated networks that in which you can actually start dividing up the particular experiences, because cognition, mood, generating action, neurovegetative symptoms all have different specific functional networks. There's a lot of overlap, but clearly by being able to isolate these, it gives us a much more tangible element for research to modulate, as opposed to a general diagnostic criteria that is nondescript when it comes down to the pathophysiology of the depression. What kind of depression are we studying? What are the specific functions that we're looking at modulating? Helen Mayberg put out a model that has become fairly widely used to illustrate this notion of either attention, emotion, the interplay. I think all models should be taken with a lot of caution, because this is really not the end of the story. It's really a hypothesis for us to keep fine-tuning our models. What I wanted to do, though, is that if you think about the history of depression in terms of research, there have been 2 major simplifications that I think are detrimental to the field. And one of my specific work has been to actually try to push them back and try to go beyond it. And as the title of the conference today is Prefrontal and Beyond, I really want to introduce 2 major ideas here that I think are very important. I'm going to pause for a minute. There's been an oversimplification about depression in terms of chemical imbalance. It's a very vague word. There's been an over-focus on monoamine, which is only 1/10 of the neurotransmitters in the brain, and again, a very oversimplification, because that's the tool that we had, and that's what most of our antidepressant work on. There's also been recently a more oversimplification about specifically these networks and where depression is, and whether really it lies in this particular region, and all what we needed to do is to essentially switch it off, change it, and move beyond to normalcy. And what I would like to propose here is that I think it's really time for us to reintroduce complexities, tangible, fairly hypothesis-based, but layered complexity in our understanding of depression. Because, as you probably know from your patient, it's much more complicated than that. One of the complexities that I want to introduce to you is this notion, and I think it's going to play out mainly in my rest of my talk today, but also tomorrow when I'll be reviewing the 15 years worth of research in brain stimulation, is that if you wanted to be a little bit more complex about these networks, then I think a fair way of simplifying it would be to think of depression and human interactions in general and the way we relate to others in two separate parallel networks. You have the medial network, by which you really attend to oneself, and you have the lateral network that you engage with the world. And as I'm speaking to you right now, I'm much more attentive to you in my space, and your feedback to me is a way to keep me engaged. And I'm monitoring my emotions through that lateral network. In a more introspective way, I'm much more activating my medial network, which is much more in touch with my inner experiences, my emotions, and to some extent, the frontal lobe is where most of that complex interactions place. If you wanted to simplify also in terms of what the frontal lobe does, and I know you're going to have much of discussions about this with the following days, is that the more, if you move from the posterior to the anterior part of the frontal lobe, you move from concrete monitoring to much more abstract construct. And if you move from the dorsal to the ventral, so on top of the head, more to the bottom, you move from cognitive to emotion. So if you imagine those two dimensions, you can get a better appreciation of what is happening in the frontal lobe and where does it take place. And my biggest focus for this particular talk is for me to try and get you into the medial part in which self-other integration takes a major role and in which the interplay with the basic emotional networks, whether it is in attachment, whether in loss, whether in stress, plays a major role. And the illustration is going to be about either using oxytocin as a way to modulate the circuit or just going there, putting electric stimulation on the surface of the cortex and modulate exactly the same thing. I want to point out to you that, empathy is a very unique thing also to humans. And it's really the idea that you can have insight about oneself and about others. And the unique thing about empathy is that it's both a way of a reflective space that is oriented outward, but it's keeping in check of what you know, so you can compare notes. And again, if there's one specific space in brain terms where empathy might play a role, it would be really in the medial aspect of the circuit that I was pointing out to you. Studying empathy can be simplified in research to a construct of theory of mind. I'm sure many of you have heard about it. I won't go too much into detail, but we really know that depressed patients also are impaired when it comes down to being able to attribute to other what might be going on, because perhaps they're fairly focused inward as part of the biology of their depression that is not allowing them the flexibility of the brain to kind of be able to really appreciate what else might be going on from someone else's perspective. Theory of mind is fairly genetically determined, although environment plays a big role. And I put out this really interesting study by Minds where the security of attachment in kids predicted also, to some extent, with 32% of the variance, their development of the theory of mind. So secure attachment affect the ability to become more empathic when you become older. And insecure attachment is a major risk for developing depression. And that's yet another reason why I was particularly interested in trying to bring in those two together, and I'll show you how we ended up looking at this in the construct of our research. So what I've told you so far is that reaction to loss, the emotional pain that some of your patients experience, the responses to stress, or their capacity to empathize, really involve overlapping networks. And within that, there's very specific neurochemistry that is taking place. One bit of notes in terms of self-other interplay, I want to share with you just 2 slides which illustrate a study that was actually conducted by a colleague of mine in my lab, Jeff Loberbaum, who was aided by Samet Kozi, a Turkish postdoctoral fellow in our laboratory, who did a lot of this work. If you get a mother that has just delivered the baby, and you put her in a scanner, and you make her listen to her own baby cries, or you make her listen to a generic baby cry, there's a big difference in how the mom would respond to her own baby. And what I want to point out to you is these are slices of the brain, obviously the feet toward you, eyes up, ears on each side, the back of the head. We're looking kind of a bottom up, and you can see a lot of activation in this medial emotional network. There's more diffuse, and I'm not going to go into the details with it a lot, but just to kind of point out to you the circuitry that get involved when you're attending to someone else that is very, very important to you, your baby, as it was just born. And alarmingly, or not, or maybe evolutionarily expected, men react very differently. They react with their cognitive brain rather than their emotional brain, listening to exactly the same. Oh, my baby's cry, I need to go attend to, as opposed to a much more gut reaction. And we see it, you can see just simply, you don't need to be an imager to really see the difference between the two. Now, if you take this, and I'm leading into the oxytocin story here. If you take moms that are breastfeeding versus mothers that are not breastfeeding, and we know that oxytocin plays a major role in the initiation and the sustaining of breastfeeding, you get, again, a much more robust activation when they're listening to their own baby cries, as opposed to mothers that are non-breastfeeding. And when you look at the breastfeeding versus non-breastfeeding in the context of someone else's cries, there's really not much difference. So there's something priming, perhaps, about the way oxytocin plays into this gut emotional reaction to a very significant other in distress. And so oxytocin and vasopressin, to some extent, as a peptides pathways, are very much involved in human pair bonding, and the literature is very large, and I'm not going to review it today. I'll be more than happy to address any of your questions. But I think one of the issues that is really interesting is that there's also been studies showing that oxytocin can have anxiolytic effect and obviously promote positive social interaction. And oxytocin, as I mentioned here, increases in breastfeeding and it facilitates attachment by getting the mother more settled to attend to the interplay of her child. Now, there's a hypothesis going on in the field of oxytocin research that oxytocin would make you trust people more, would make you love people more, would make you more in bonding with other, and I'm the outlier in a sense. I don't think oxytocin does so many things, but fundamentally what oxytocin does is it gets you settled in the moment. If you think about a mom who's about to breastfeed, she's running around, there are a lot of things happening, and at one point when she is able to begin breastfeeding, she's almost zoned out. She's very focused on the moment. And that focus on the moment, getting settled, getting more of the primary emotional aspect working, and the primary emotional processes working, and I'm using a psychoanalytical term here because I think the interplay is fairly interesting, give root to a more attentive and perhaps a fertile ground for the attachment to take place. So in a way, oxytocin is not the attachment. Oxytocin is the facilitator for that attachment. As opposed to, there are a lot of other theories, but I want to take you through that because I don't want to overstate what oxytocin can do. And so in that context, with that background that we've done in our lab, there came about a hypothesis, which is if depression pathophysiology has really something to do with insecure attachment, with stress, with loss, could then oxytocin alter the brain activities of the specific networks that we know are involved in attachment, stress, loss, and the relationship to other, and being able to probe that. And so what we designed is, I think, one of the first studies to date of oxytocin in unmedicated depressed patients, and we primarily focused on an imaging study because it was a challenge study, it wasn't a treatment study. We just gave oxytocin one time versus placebo, and we wanted to look at the brain mechanisms that are taking place. We did a lot of subjective ratings. We had a psychoanalyst interviewing a patient blind to the randomization and taking note, which is a separate presentation on its own. What I'm going to focus today is about the specific changes that takes place in the brain of a depressed, on medication person who had just inhaled oxytocin versus a matched healthy control. And so the study is really fairly simple design. Everybody got evaluated at baseline, very comprehensive metapsychological assessment and psychiatric assessment. We bring them on the first week. We do an fMRI study or another brain activity study looking at the specific functional connection between specific region. I'm going to detail that in a moment. With the amygdala, with the cingulate, as well as with the subgenu cingulate. What I want to point out to you here is just this one simple message. Look how the shift from cognition to emotional processes, the yellow is before the oxytocin, the purple or red is after, and how essentially oxytocin is trying to prime more of that attachment emotional. Interesting also is that more of our depressed patients were able to tell which drug was the real oxytocin and which one was a placebo than our healthy controls. And to some extent, they were the one that felt the more settled in the moment as opposed to our healthy control. There was a hint actually of increased sadness with the oxytocin administration but the numbers are small, so one should take this with caution. So modest behavioral effect, very strong changes in brain activity favoring medial ventral emotional region with oxytocin administration, and as I explained to you, a very, very different story between the depressed and the healthy control, which kind of argue again of the pathophysiology of what might be taking place in depressed. Now, I bring you this because, I'm very excited about the studies, and actually the result that you just saw right now has never been presented before, and this is what was alluded to as the latest data kind of emailed to me yesterday. And I put this talk really as a way to try to get you in the moment of the topic of the Congress, which is looking forward as to where should we be moving. And I thought many of you may not attend my CME tomorrow about brain stimulation, and I wanted to bring you in my last 5 slides to something fairly new that, again, hasn't been done except in our lab. No one else in the world has done this approach. And again, to get you a sense of how we're approaching depression in a little bit more complicated overlapping network, primarily distinguishing between this kind of lateral attention to the world versus medial attention to the internal experience. And so what I'll be taking you through in my last 5 minutes of the presentation, and I'll be detailing this much more tomorrow, is the idea of using surface brain electrodes linked to a pacemaker, similar to what you would have for a heart pacemaker or for the deep brain stimulation in Parkinson. But instead of having the specific electrode into the basal ganglia, for instance, for Parkinson, we're essentially laying the electrode on the surface of the cortex. And again, because the prefrontal cortex does different things, different places, as I explained to you, more abstract as you move forward and more emotional as you move ventrally. We kind of devised this notion, and we wanted to see whether stimulating the brain can really play a role in very, very treatment-resistant depression, and to understand why. And this whole research has actually come about from this notion that brain stimulation doesn't need to require seizure like electroconvulsive therapy does in order to induce a therapeutic effect. And so there's literature now with transcranial magnetic stimulation, vagus nerve stimulation, that both have been approved for treatment-resistant depression, but research in deep brain stimulation and kind of briefly this epidural prefrontal cortical stimulation. If you put this network again, depending on what you're tapping into, whether with TMS, with the epidural cortical stimulation, you're implanting deep electrode in the brain, or you're stimulating the vagus nerve, you're accessing a network from a different spot. And this is a schematic of where we're putting the electrode over the anterior pole, so the equivalent of Brodmann area 10 bilaterally and Brodmann area 46. This is a lateral view, again, with the first strip and the second strip. The study is fairly open and preliminary at this point. You can imagine that patients were very sick getting into the study, and we essentially implanted them, did a number of imaging to try and understand. I'll take you through one result in a moment. Started stimulation 2 weeks after surgery, held everything constant, including meds, for about 5 months, and then we began also a naturalistic follow-up. Only 5 patients implanted so far, all of them unemployed, 4 of them on disability. They had failed vagus nerve stimulation, 3 of them. They had failed ECT. And if you look at the average antidepressant history failure in the current depressive episode, they had failed over 5. Now, if you take the STAR-D data of the antidepressant response, anybody who has failed more than 3 in the algorithm is expected to have 0 remission afterward. And so you're talking here 6, and some of the patients actually had 7 and 8 into this. And so the implant procedure is done very stereotactically, and this is kind of an X-ray showing you the 2 leads on the right side and how one would come over the prefrontal anterior pole and the one the lateral pole. And this kind of I'll be detailing these more, but the trick here is to show you that if you do structural connectivity study, you can see that the electrode really connect to this kind of a subgenual cingulate area as well as to the amygdala by either taking kind of these lateral pathways in yellow or the green ventral pathway. So again, we're accessing structurally, and I'll show you in a moment functionally, different network. And if we go back to the same paradigm that our oxytocin patient did in terms of mental attribution and capacity to empathize, when we stimulated only the medial electrode, the one that comes over the anterior frontal poles, and asked the patient in a blind way to do this task. This is a patient, I don't know if you can see her scarf, but she had just had the brain surgery 2 weeks ago, and so this is the first time she's been activated ever in a laboratory and doing this task for the first time. You can see that by stimulating the medial prefrontal cortex, their reaction to make those decisions are faster with the stimulation on versus the stimulation off, and there's really not much different when they're just making a simple gender attribution, is this a male or a woman? And if you remember, again, very small data, but if you remember the STAR-D data, where whoever failed three antidepressants, it would be expected to have zero remission. We had on average 5, they failed ECT, 3 of them, they failed vagus nerve stimulation and got explanted. By 4.5 months, 3 of the 5 have reached remission. And actually you can see that the 4th patient had reached remission 8 months into his active stimulation, did relapse, and we're now in the process of trying, hopefully, to shorten his depressive episode, which last one was 5 years. The same with this patient that had a depressive episode of about 2 years coming into the study and had been in remission for 9 months, had a relapse, interestingly, on the anniversary of losing her pregnancy and losing her twins. So the anniversary came on, she relapsed, but luckily actually came out of her depression within less than 2 months, whereas before she had been on average in a depressive episode for about 2 years. So the last slide, and I'm actually at 1 minute into my talk, by having a really comprehensive approach to the pathophysiology of depression, by integrating construct of loss, which are fundamental, I think, to the pathophysiology of depression, of emotional pain, this kind of really internal experience that kind of makes you unable to attend to someone else. The fact that stress and relapses are such easy and common phenomena that takes place in chronic depression that tips our patient back into their depressive episode despite very aggressive treatment. And by integrating these overlapping networks, we can begin to fine-tune treatment that goes beyond a simplification of the chemical imbalance in the brain, of the simplification of this one spot in the brain that can do it, and essentially, hopefully, lead to more effective treatment for patients that are really, really asking us to give them that. This work takes a lot of collaborators. I wanted to point out, actually, Samet Kozi, again, a postdoctoral fellow from Turkey, who's been in our group for 6 years and kind of did a lot of the hard work in collecting the imaging data with the Oxytocin study. I mentioned Jeff Loberbaum with his baby cry studies, and Steve Kakash, who's the neurosurgeon that kind of went along with my crazy idea before anybody else kind of went into on board and actually was able to help me this. More importantly, I have to thank the patient who have, in over 15 years of research, have collaborated to my studies and helped me understand them a little bit better. And with that, I will end. Tashakkur.